Good evening, good evening, good evening, and welcome to Couch Conversations with the Doctors. What night is it tonight? It is Monday night, and Monday night is Couch Conversations with the Doctors. So we want to say hello to all of our Facebook, Instagram, Periscope, and all of our social media family. Thank you guys for stopping in and stopping by. Remember to share, and share as always. Couch Conversations with the Doctors. We're going to go around as we always do, and we're going to introduce our panel here to you. As always, I see that I have Dr. Miller here, the man who says that I threatened him to be here, but he's always on time. Dr. Miller.
Good evening, everyone. We're so happy to be here and to answer what questions you have and share what the information we have about healthcare, and hopefully can give you some information that can make you healthier and live a longer life. So,
Simply wonderful. To that guy who says he's an extraordinary dad, that's our very own Dr. Bonnie Pete Thomas, that is. Dr. Thomas.
Hey, good afternoon, guys. I'm excited to answer some questions and see what we might be able to clarify for everyone this evening.
Wonderful. To my coworker, Dr. Douglas Graham, who is hanging out with us on this evening. Dr. Graham.
Hey, good evening, everyone. I, like Dr. Mel, I'm also a retired physician. I'm going to try and answer your questions as best I can. I'm glad to be of help.
Wonderful. And to that gentleman who really has a burning sensation to be on Iron Chef because he's that weight loss guru, that's our very own Dr. Tony Hampton.
Hey guys, I'm happy to be here tonight. Family doctor here on the south side of Chicago, and always happy to share a message of healing with you guys. So let's have fun tonight.
And to the one who makes this all possible, the vanguard of healthcare, that's our very own Congressman of the Illinois 7th Congressional District, Congressman Danny K. Davis.
Well, thank you very much, and I'm delighted to be back in Washington, District of Columbia. We've had our one vote for the day. It's a little bit later here than it is there, but I also had a tremendous weekend. We had a great press conference on yesterday announcing the $3.2 billion that the Federal Communications Commission has made available, especially for low-income individuals to be connected to the internet, also to be able to purchase computer equipment, and to get much of the assistance that they really need so that they will be able to communicate. There are so many wonderful, wonderful things that are going on until it's just unbelievable. Even the funeral services that I attended over the weekend were just great going away opportunities, especially the one for Bernie Wong, the lady that I call one of the best social workers that has ever functioned in the United States of America. Is a Chinese American woman who ran an organization called CAStle, the Chinese American Service League. And of course, she started it with nothing. And now it's about a $12 million a year social service agency employing about 400 people. And she passed away, and it was just so great to see all of the people who turned out for her services, including the mayor, Senator Durbin, of course, myself, Tony Preckwinkle, Theresa Ma. All of these are people who are elected people. So health continues to be wealth. We are still urging people unequivocally and without a doubt, if they have not been vaccinated, please don't let up. Don't believe that you are safe because you're young. The young fella on my staff just informed me a few minutes ago that he tested positive. And I was just certain that I said, well, did you get the vaccination? He said, well, I had not. I said, you gotta be kidding. I mean, that's hard to imagine. As much as you've been around, and as much conversation, well, we just kind of waiting. So don't believe. And so tomorrow morning, I'm going to go and get tested again, even though I have had, both shots of vaccination, and I don't feel any different or any way of anything. But I'm going to go and get tested first thing in the morning so that whatever chance there might be that I might come in contact with someone and spread the illness or the germs or the virus or whatever. I don't want to do that. So if you haven't been tested, make sure that you do so. Thanks to everybody who's on, and we're ready to roll.
Okay, that's wonderful. Let's say hey to Leanne Harrison's here. Hey to Martha, who is also here. Lanya Williams is here joining us on this evening. Linda Johnson, we see you, and she says good evening to everyone. She's saying good evening to everyone. So I guess we can just jump right into our questions. One of our very first questions of the evening says, I'm Devin. My question is, how important is personal hygiene? I've traveled the world and other countries don't view it as important as we as Americans do. Are we putting too much into this?
Man, that's a question that when you're a doctor, you try to be a scientist as much as possible and not just go about what your grandmama taught you or what they taught you in kindergarten. But some of this is what they taught you in kindergarten. And I think when you're in a pandemic, hygiene seems like a natural thing to do, So when I go into the bathroom at my clinic, I want to have good hygiene because I'm actually about to then come out and interact with patients. So I think that type of hygiene is just being respectful to your the people you work with, the patients I see, and just society as a whole. You don't want to be not washing your hands in the bathroom and then you're going to shake somebody's hand. That's being disrespectful to them, I think. When I think about dental hygiene, I think it's important that you not only be respectful, you want to kind of make sure your breath is appropriate and things like that, but also we have a lot of people who come to the clinic in their 50s and they need to have their teeth replaced, right? So if you don't have good dental hygiene, and my colleagues could speak to the medical conditions that are not necessarily going to serve you well if you have poor dental hygiene. So I think that's important. So for me, it's just common sense to have good hygiene. I have been in other countries where they don't wear deodorants and things like that. It's a cultural thing and they have their reasons for it. But for me, it's about when I'm going to have contact with another individual and I want to preserve my teeth, I think having good hygiene is a good idea. So are we overdoing it? We absolutely, at times we overdo it. I mean, I've been washing my desk down, daily when I start my day. Is that overdoing it? Well, when you don't know things, if you don't have all the answers, then it's probably okay to overdo it until you get more answers. And then as we get more data, then we make different decisions. I remember a time when you're supposed to wipe things down and let it sit for a certain amount of time. And that way you kind of know the virus, so as we get more information, we make different decisions. But as a general rule of thumb, I think good hygiene is a better way to go than to do the opposite.
Yeah, I think to your point, Dr. Hampton, it's important to, do sort of what we call common sense things to help keep yourself safe and people around you safe. And I think at that very same time, you want to avoid making over associations, right? So I think one of my colleagues said, association does not necessarily mean causation. So just because someone doesn't have good body odor does not necessarily mean they have a higher infectivity rate of COVID, right? So they may not do a good job of washing up, but that doesn't necessarily mean that they're going to have a higher rate of contracting COVID or any other infection. So, that being said, I think, you do think about hygiene in the sense of not just for yourself, but for the community, and making sure, especially with us as healthcare providers, that we're interacting from one patient to another patient. And to me, that's more of concern than just personally wanting to. Yes, I want to smell good and feel good and all the rest of those things. But what I don't want to do is, give what patient X has to patient Y, and so that's why you want to make sure your hygiene is good. But I think it's important not to over associate. So just because we smell good here in the U.S. and we like our little fragrances and all the rest of that does not necessarily mean that we're either healthier or we either less likely to get infected.
Yeah, I'll just add to that is again, everybody's saying this is a common sense kind of thing in terms of keeping ourselves clean when we are interacting with other people. It's it's number one, respecting others as well, and so common sense say that that if you're going to do certain things, you should certainly wash your hands. And if you're going to be interacting, shaking other people's hand, and you've been in a situation where maybe your hands have been in contact with a virus or bacteria that can be spreaded and cause other people to develop an illness from that. So you would want to make certain that you wash your hands. And there is a saying that cleanliness is next to godliness. And the process here is let us again use good judgment and good common sense. There are things that it has to do with cultural differences in terms of how people what people put on their body. Also, sometimes odors and things that one's body has is not necessarily related to whether or not you wash. Sometimes it may be related to things that you ingest. So again, so it's Dr. Peach said, let us not be so judgmental of other folks, but let us all use good common sense in terms of how we conduct ourselves and how we prepare ourselves for whatever the conditions are going to be. And if there's ever a situation where you would err, it's better to err on the side of overdoing it than underdoing it.
I just try to keep it simple. An ounce of prevention is worth much more than a pound of cure.
Absolutely.
And so if you can just prevent something from happening, then you don't have to correct it later on.
All right. So, let's say hey to Nellie King, who is here. Nellie says, good evening to everyone. Virginia Knight says, afternoon all. Afternoon all. Cassandra is here with us as well. She says, good evening to everyone, and that she has shared this information that we are sharing on this evening. Edna Weatherspoon says, good evening all. Audrey Jaycox is here, and she says, good evening to everyone. And so does Sister Bonnie. She says, good evening to everyone who is here. Our next question says, is there a real difference between dementia and Alzheimer's disease? Also, should relative caregivers be concerned about inheriting this gene? And is there respite for a caregiver? So there's a couple different questions in there that we got. Tamika Thomas, we see you out there. Good evening.
Yeah, I can start off on this one. So Alzheimer's is a specific type of dementia. Dementia, in general, is considered to be a loss of cognitive function, like your inability to think through situations that you would ordinarily have. That ordinarily would you would get, that you would have information for. Also, it's a loss of memory. So dementia can happen from a variety of things: vascular disease, genetic disorders, um, Parkinson's. But generally speaking, Alzheimer's is a diagnosis of exclusion. So, which means if so you come in and you have, and let's say the wife comes in and says, my husband has having memory problems. I think he has dementia, or she might say, I think he has Alzheimer's. Well, before you can specifically say they have Alzheimer's, you really do got to rule out all these other things that could cause lack of memory. You got to make sure their thyroid function is okay. You got to make sure any sort of metabolic problems. I know my brother, Dr. Hampton, likes that word, metabolic. Any kind of metabolic problems are happening. And just so that we're clear, Alzheimer's is there is a genetic portion to it, but it is a very much lifestyle and environmental causation as well. So it's those factors come together. We talked about it before, the epigenetic factors that can play a role in this, and social determinants of health, trauma, all those things, plus diet and genetic predisposition. I don't know anybody else want to comment on that.
The comment I'll add is I'm thinking about this. Is there a respite? And the answer is I think that really depends on factors like insurance coverage and things like that. But yeah, most of the times there is an opportunity to have respite, and that's a great question because you will get you'll be sick yourself trying to take care of somebody with dementia. And I personally know what it's like because in my own home, I have my wife's dad and we take care of him. And so even with a doctor and a pharmacist and kids and everybody else in the house, it's a lot of work and it's unimaginable. And I think of all the things I do as a physician, if I had to say what's the top 5 medical conditions that impact the family, I would clearly put dementia in the top 5. I mean, it's like it's such a, and you're not really prepared for it, and people get it at younger ages. So the question about heredity, I mean, we do have certain types of dementias that are hereditary, like Huntington's, and you can look that up and learn more about that. But most of them are not hereditary, and it should be obvious to you that it's not hereditary, because why are so many people today getting dementia when they didn't 30, 40 years ago? That's not hereditary. That's environmental something that's happened. Now, I would argue, as Brother Pete has suggested, I would say one of the reasons is metabolic health being poor. In other words, if you have a state of inflammation in your body and you don't, and you constantly keep that inflammation, rather it's from stress, rather from lack of sleep, and primarily from diet, then that inflammation is going to impact your brain. And, when think about sleep, when you go to sleep, that's when your body cleans out the debris in your brain. And you'll hear terms like, plaques and tangles and things like that occur with certain types of dementia. Well, those plaques and tangles, amyloid plaques to be specific, will never accumulate in your brain if you get enough sleep. And that's when your body, gets that stuff out of your brain. When you're trying to fuel the brain, you generally fuel it with, either glucose or ketones, which is fat fuel. And the problem with your brain is very smart. And if you give it too much sugar fuel, it's going to shut down and tell your brain not to let all that glucose or sugar in. And when that happens, your brain over time is going to not have a fuel source, and it's going to start to shrink over time. And that's why every time we do an MRI of the brain with people with dementia, their brain looks smaller than it should have. And we'll see the ventricles, which are the spaces, will be larger because the actual brain is smaller. But then So what do you do when you don't have adequate fuel from sugar? Because it's a very dirty source of fuel, and it causes more inflammation, and your brain doesn't like that. Then you start to think about another source, which is ketones. And so if you get a diet on board where you have, clean fuel from ketones, you can help people. So for those who want to learn more about that, I recommend the Alzheimer's Antidote, which is a book by Amy Berger, and The End of Dementia, which is a functional medicine kind of book that talks about how you can change your diet to reduce your risk for dementia. So I would not be as focused on family history. I would be focused on lifestyle. And if you have the proper diet, you get sleep, you keep your stress down, then your risk for dementia will plummet. But we live in a very stressful time. People don't get sleep. They eat a lot of fast food. And that's why the rate of dementia, I think, is escalating.
So let me ask, there are similarities between, many people seem to think that the two are kind of like cousins, first cousins, maybe. The big difference between the two is what?
Oh, you like Alzheimer's versus
versus dementia.
Yeah, well, let's throw dementia into a big bucket category that it's like all of them. Let's just call them all dementias. And then you get into Alzheimer's dementia. Then you get into vascular. So, and they're similar in that maybe the inflammation also led to Alzheimer's, and the inflammation clogged your arteries and led to vascular. So they're similar in etiology, but so if I have a person that's had a heart attack or a stroke, I know their chance of getting vascular dementia is the same, because guess what? Heart attack and stroke is a vascular disease. Therefore, you're going to have a fuel supply issue to the brain. So, but in general, I want everybody listening, dementia is all of them. And then you have Huntington's and Alzheimer's and, all kinds. It's a whole list. And that's why we have specialists, neuropsychologists, who we sometimes have to ask to distinguish, because it can be a little challenging. And some of them you can't diagnose until you do a biopsy of the brain. So I don't want to diagnose it. I don't want to get my diagnosis then. I want to.
Congressman, I like to use the example. It's like saying you live in Chicago, that's dementia. But then you can say, I live in the community of Austin or Hyde Park or Beverly. Yeah. Well, that's the specific type of dementia. So that would be like Alzheimer's versus Huntington's versus vascular. So that it's like a specific type. And in general, Alzheimer's is a diagnosis of exclusion. So you have to exclude all these other ones first, and then you can get to Alzheimer's. Because in general, you try not to biopsy people's brains. So you want to rule out all those other things first that are obviously more common, right? So vascular disease, number one killer of Americans has been for the last 60 years. Well, that's the number one cause, right? But then as you move down and you start to rule out via MRIs and lumbar puncture tests, and then you get to the point where, you say, okay, this is likely Alzheimer's disease.
Yeah. Well, I'm going to try to stay in Austin.
So I can just want to add a couple of things here. And because also part of this question is about the respite. And that's an important dynamics that takes place when there's an individual that has Alzheimer's or has dementia, because now there's a family dynamic that is affected by this individual's disability, and so having respite, having other kinds of support to help that family to be able to adjust and to deal with it. Because I've had patients in the past. The whole idea was that grandma or mom is getting dementia, and it's not like it's a kind of that they're kind of cantankerous or they don't understand certain things, and you can't just explain it to them 5 times and expect for it just doesn't occur. They've lost that ability to understand. So and so just as they've lost the ability to understand complex, they also lost the ability to understand some very simple things, or they've forgotten how to do certain simple things. And that has a significant effect on families in terms of if there's how many people are there that can help to support this family or support this individual. And if it's only one or two people, that becomes very stressful on those individuals. They do need to have a break. They do need to have some kind of way to be able to recoup and to regenerate. So, as we look at this and, in terms of the things that we do about dementia, again, if we can find disease processes that are going on that we can change, then that's good. But most of the dementias don't really have a specific kind of good treatment that's going to reverse the process and make that person better again. So that it's very important for families to understand what they're dealing with and how they can sort of adjust and how they can get whatever support they need so that they'll be able to manage with this individual.
All right.
Simply outstanding. Simply outstanding. Barbara Ivory says that she's watching. She's here with us. Rosetta Goff says good evening to everyone. Barbara Ivory also says, Dr. P, illness affects me in that way.
What was that, Nikki, again? Sorry.
She says, Dr. P, I'm having problems with my memory since COVID. Could my illness affect me in that way? So I'm maybe thinking, maybe she's saying that she had coronavirus and that she's maybe having some memory loss behind it, I think.
Yeah. So we do know that there is a percent of patients, around 10%, who have what we call long hauler syndrome, which includes cardiopulmonary symptoms, but also neurological symptoms like loss of memory, feeling foggy, your sense of thinking you're not as sharp as you were. We're not sure why that is. We think it might be vascular, but there is a percent of people who do have this. There's a number of long hauler syndrome clinics at some of their hospitals around the city. I would highly recommend that you go there because they have a specific set of doctors that are sort of skilled in that area of taking care of patients who had COVID, who are having neurological symptoms, or who had COVID, who are having cardiopulmonary symptoms, which means shortness of breath or chest pain or fatigue, not your usual energetic self. So yes, but it is it's well recognized that there is a percent of patients who have it. It's about 10% people who have had COVID. So definitely recommend. I know Northwestern has one. I think Rush has one. So
great. Bob Ivy also says, Dr. Tony Hansen, thanks for saying it's not hereditary. Karen is here and she says, good evening to everyone. Evelyn Shelton says, Dr. Hansen, my mom has experienced dementia since suffering a stroke last year. Is it reversible or progressive, no matter what?
Well, I think this is a nuanced question. Whenever you have a stroke, the sooner the better in terms of how well you're going to do. So I tell anybody, I've seen patients who have a stroke and they just hit it, and they get the rehab quickly, they get the speech therapy quickly, and they go at it like Michael Jordan used to go at it, and they just do well. They're never back 100% to where they were, but they definitely do better than the person who doesn't do that. And a lot of this is mental, because a lot of what you suffer from is you get kind of depressed, having lost some of your function and your identity and who you were and what you're able to do, and having to depend on people when you're used to being independent. So the longer we wait to help her, the less likely she's going to get recovery of her nerve cells. Now, having said that, a stroke is different than a dementia that occurs over time due to maybe your diet and things like that. So if you get somebody earlier in the process and they hadn't had a stroke, and let's just say they have mild cognitive decline and when they're starting to have memory problems and they're just not as sharp, if you can get that person at that point to make changes, there's a substantial uh, benefit of that, and you can really start to see improvement and things get better. But again, most of our conventional docs are not trained in, doing a dietary approach. So you're not going to find that in conventional medicine. But the message that you want to hear me say, though, is that a lot of inflammation from inflammatory foods is what drives this. So what you want to do is remove processed foods and things like that out of your diet. So the short answer to your question is that there's always an opportunity to improve things. I wouldn't call it progressive. If you make substantial lifestyle changes overall, you can kind of stop the bleeding in a sense, and then you can actually keep it from getting worse. But it's going to require a lot of dedication and work, not only for the patient, but for the family to kind of push them and support them through that.
Yeah, and I just want to add to that. It also depends how big the stroke was. So a small stroke or part of the brain, a small area of the brain, or the less brain tissue that died, the better. And tends to be the better prognosis, the better opportunity. The larger the brain tissue that died, which is the stroke, the lower the possibility of you returning to normal, or it'll be a harder struggle for you to get back to where you were.
Great. Barbara Ivory thanks you both, Dr. Hampton and Dr. Miller, for answering her questions. Evelyn also says thank you. She was getting that information prior to COVID happening. And she thanks the both of you just as well. Barbara also kind of explained it was after the COVID thing, but she just gets really foggy and she kind of feels ashamed when her students approach her and they want to hug her and have conversations. She says she remembers their faces, but she cannot recall their names. So hopefully some research will come out and say when that's going to come back. But thank you, Dr. Pete, for answering that question. Mimi says, hello, everyone. I want to know if eyes or face tremors considered a stroke or stroke symptoms.
Not all at once.
Right.
You said face tremor?
Yeah.
Yeah.
If you mean twitching of muscles in the face, it may not. I mean, there are a number of things that can cause that. Obviously, it can be due to a stroke, but there are other kinds of things that can cause individuals to have. The most common thing we call the tic, and that can sometimes be due to electrolyte imbalance, and especially potassium. Sometimes it can be due to people with anxiety situations. So it depends on, if you just have twitching and it goes away, it doesn't come back, then, it's not likely to be due to a stroke. I mean, even people sometimes have focal seizures, which could also cause facial twitching. So there's a number of causes for facial twitching other than strokes.
And something that a lot of people have used. I don't know if you all can hear me. Yeah. Oh, hey family. Sorry I'm late. Thanks for having me join. Something that a lot of people use is that fast. It's like a trick that help us remember signs of stroke, and it's facial drooping. And like Dr. Miller said, sometimes my face droops, but my muscle is trying to come back and may do this. But it's like one side of your face then just kind of loses the the expression. Arm weakness is the next one. F is for face drooping. A is for arm weakness. S is for speech difficulty. So if I'm talking and all of the sudden I start doing this, and that's not my normal speech pattern. My speech pattern changes. Sometimes people have been known to be talking and I'm speaking in my, black girl magic, accent, Ebonic accent, and all of a sudden it changes to another accent. That's a phenomenon we've seen. Like I've never been to a country, and all of a sudden I get this like, on the spot accent. So, and then the T is for it's time to call 911. So when you see face drooping, when you see arm weakness, when you see changes in speech, it's time to call 911. And that is uh, the we call it an acronym, but that's the kind of thing that, I mean, mnemonic, but that's the thing that kind of make us think about a stroke might be happening. But it's a mnemonic, not yes. So fast.
Yeah, and I just want to also add to that, Dr. Meyer. Thanks for that. That the key is the time that you get the person to care, where they can get the blood thinner in their system to resume blood flow to the brain, to that part of the brain. So that is the key, and I think it's 90 minutes you have that basically to get that person when the family member or somebody notices that this person is drooping or the person their speech is not what it normally is, and they start doing that to get them to the hospital where they can get to the ER, get the blood thinning medication within their system, usually less than in less than 90 minutes.
You know, Edna Weatherspoon says, I have seizures with memory loss. Could I get dementia later? I think she means get. Could I get dementia later?
I think I'll just be rational about this when I'm not looking at data or studies. But anytime you have compromise to your brain of any type, I think that there probably is going to be a slightly higher risk. But in no way should that mean that you're going to have that problem. But I do think that people who have a lot of seizures, they do tend to have memory problems over time. You really want to really try to reduce the number of episodes if it's medicine. I mean, we have so much technology at Rush. They actually do surgery for epilepsy, right? So if medicines don't control it, the key is to always ask your clinician more, like, okay, this is not working. If I got to go to Mayo Clinic, just keep asking for more until you get a solution. Luckily for us, most people will respond to medicine. But yeah, if you have uncontrolled seizures, if you have uncontrolled diabetes, if you're always a low blood sugar, you're going to have problems with your mental capacity at some point. Your brain needs oxygen, and if you cut it off because of a seizure, you cut it off because of a low blood sugar in any way, that's like a micro trauma, and over time that's going to start affecting how your brain functions. So I think that's the best answer I can give.
Mm-hmm.
Wonderful. Our next question says, should someone who has Alzheimer's be in the hospice?
I think it all depends on how bad it is. I think in general, your earlier stages, can be managed, without hospice care. But to Dr. Hampton's point earlier, I mean, it does take a toll on the family, especially when you have, families that are working, that they have to work to make ends meet. And then you're worried that, the loved one might do something or, put a shoe in the oven, leave the house, get where they're going. I've heard so many stories from my patients who have told me, dad got in the car and drove someplace and didn't know where he was. And it's really traumatizing to the family members. And even though I'm not their doctor, I'm the dad's doctor, but it's traumatizing to them that somebody that's such a hero to them or their whole life. And then all of a sudden, this person is slowly sort of slipping away, if you will. But when we hear these stories, the earlier we know about them, the earlier we can get them into care. And I know we keep harping on Rush, but Rush doesn't have a great memory clinic there. And the sooner we can get people there, where they have sort of cutting edge technology and cutting edge research that's happening, and it's a great resource to have in Chicago. You don't even have to go to Mayo. we can go right here, especially specifically for people who we think might have dementia.
Mhm.
That's a good point, Dr. Pete, because University of Chicago is Harvard. Let me just say that. Like, there's no difference between Harvard and University of Chicago. So if you never knew that, I'm glad I'm saying it right now. Northwestern, these are some. I mean, we have all them bunched together, and we're so fortunate to have those great resources among us. So now, having said that, I just want to say this out loud. I sometimes have to fight with my colleagues about palliative care. I'm being honest. Now, you would think that clinicians who specialize in certain professions would just automatically send people to palliative care. So what the heck is palliative care versus hospice? Well, palliative care is supportive care. You can actually have medical conditions like COPD, chronic obstructive pulmonary disease, congestive heart failure, and you can have a life expectancy of 10 years and be in palliative care for 10 years. Why? Because they're just supporting you. And maybe they know how to do things in a way. Maybe the primary care doctor doesn't know how to treat the COPD, I'm having trouble breathing, as well as a palliative care doctor who knows how to keep people comfortable, even if they are going to live longer than the 6 months that go under hospice. So I personally think everybody with a condition like dementia and cancer and COPD should be considered for palliative care. It's just an underutilized, but they tend to be the same clinicians, but it's a completely different set of resources. And whenever they look at studies, particularly for things like cancer, like lung cancer, people who do palliative care who have lung cancer live longer than people who have lung cancer and don't get palliative care, because you get all the support that you and your family, going back to dementia, they need that support. They need to know what it's shameful to have resources that maybe our congressman fought for, and you don't even utilize the resources because you don't know they exist, because your doctor doesn't know, but the people on the palliative care team know, because that's what they do. So I really want to just really encourage people, don't be afraid of those two words. Hospice, maybe they think maybe you got 6 months to live, and it's a different set of resources. And palliative care, you still take all the treatments you normally get, you get with palliative care. I just think that it's underutilized, and I want to make sure people distinguish between those two. And at the minimum, talk to somebody so you'll understand the difference and find out if there are resources that will benefit you and your loved one.
Yeah, I think that was an excellent thing to point out, Dr. Hampton. One of the big problems I think we have is, especially in this country, is dealing with death. And so especially when you start talking about these terms, hospice and palliative care and those kinds of things, people are reminded that somebody's going to die. And we don't deal well with that. I think palliative care is an option that allows people more time to adjust to maybe losing that person that is maybe sinking away from them. And I think as a society, we got to figure out also better ways of dealing with these something that's so certain for everybody. That's, death is certain. It's gonna, if you live, you're going to die. So, but somehow we do not deal with it very well, and somehow we kind of think that if I don't think about it, I don't deal with it, maybe there's an escape. But the only escape is the escape that I can sort of hide myself from something that is going to get me, regardless of what I do. And so I think that palliative care is certainly an option. I think that that families need to consider in all these kinds of situations where you have a disease process that is not reversible and is likely to progress over time. Because at some point in time, you got to figure out now, what are we doing and why are we doing what we're doing? Are we doing something that's going to be helpful and to this individual who has an illness, or are we doing this because I have not, as a family member, had gotten to a situation where I can deal with the loss of that individual?
Well, Dr. Miller, let me just ask, are you suggesting that we would do well to spend more time preparing people or helping to prepare people for the inevitability of death.
Absolutely, absolutely. It is something that they're going to have to face, and sometimes it's not the individual that's dying that's the problem. It's the ones that they're leaving behind that have more problem with them dying. Sometimes the person who is dying may very well be adjusting to it, but their family has more difficulty because they are the one that's going to have to deal with the loss. But yes, I think that we should begin to prepare people to deal with not just our individual death, but the death of our loved ones, and we don't do a good job at that.
Just,
So I've got
just
a
one
question.
final, really. Oh, go ahead, Doctor.
Yeah, I'm just curious because I wonder if any of the doctors in the panel have had the experience of having either intermittent hospice or palliative care, because sometimes you might be under the impression that it's a one-way street. But I think there are circumstances where people go back and forth, which may give some caregiver respite and allow people to kind of get recharged and reorganized and better prepared.
Mm-hmm. And yes, I mean, if you're in a hospice situation and you start to improve, you absolutely can leave a hospice situation and maybe go to palliative or just go to. There's no question. I think the bigger problem I think we have in our society is that we have created a specialty, palliative care, to help our doctors who are just as uncomfortable as the patients talk about this issue. Their job is to say, what's the goal of care? Like, so if you have a family member and they're being, treated for cancer, for example, your first question you should ask the doctor is this curable or not? Is this, am I doing this chemo to cure this, or am I doing this to prolong the inevitable, as Dr. Miller has suggested? They should be obvious questions, but what we as clinicians, we're trained to fix things, right? So my gut instinct is I'm going to start treating you no matter what the outcome is. But I really need to, if it's spread somewhere, it's the chances of curing metastatic cancer is near zero. So if that's true, then what are we doing here? Because I have seen patients who have a life expectancy, and it's a guess, but let's just say they have 6 months to live, right? And then if they do chemo in that setting and that it's metastatic, then maybe they spend 2 to 3 months doing a treatment that's going to make them feel horrible. So some people elect not to do the treatment so they can, and then they take a trip to New Orleans where me and Brother Pete went to school, and they get the Mardi Gras thing going and have a good time because they don't have a lot of time and they don't want to spend that time being sick. But if nobody ever asked them, what do you want? Because they never told them what's going on, that's a disservice to the patient and the family. So all I want is that our society be more comfortable with death. If you're not comfortable as a clinician talking about it, send them to palliative care who they're comfortable. And then the patients have goals of care that align with their vision. They may say, I just want to keep me around, doc, until somebody graduate. Keep me around until, I get, we're still going to get married, even though I just been diagnosed with pancreatic, So we just have honest conversations, and we're just not comfortable, as Dr. Miller has suggested. And Dr. Graham, we're just not comfortable, and we need to become more comfortable.
Well, at church,
that's the interesting.
People said they wouldn't mind dying if dying was all. if that was the end of it. But it also talks about don't be ignorant of the mysteries of death. And so for as long as we can remember, there have been notions about this, but we just haven't gotten as much into it as perhaps we are beginning to get into it a bit more. I can remember when we didn't have a lot of hospice care. I can remember when hospice was becoming. I can recall when this notion of continuum of care was a big discussion. And I had some young physicians who spoke with me earlier today about starting a practice. And I was suggesting to them that it may not be as easy to do the solo practice piece as it used to be. And I don't know how successful, because they didn't indicate that they had any money, and so we talked about capital investment that is needed to go into the private practice of medicine, which seems to be becoming pretty much a thing of the past, unless one is in a situation where they're able to kind of merge into an ongoing operation and they become a part of it, or maybe their family has a clinic and they transition into that. But there are a lot of things, I guess, that really have to be considered in terms of how we practice medicine and what kind of practicing there would be.
Yeah, Congressman, I think you bring up a good point, and I think I'm sort of amazed, like Dr. Hampton said, that when you have people who are in the care of specialists, you're just amazed that this wouldn't be a natural progression, that people wouldn't just say, okay, I have a really, really end-stage COPD patient, and you're seeing pulmonary every 2 months. Why wouldn't it be a natural progression for them to refer you to palliative care, right? Because those are the people that are very familiar with getting you a hospital bed, getting you the oxygen that you need, all of the things that, quite honestly, if your primary care doctor is not used to ordering, and we might order it wrong, and then that's another 6 weeks you got to go getting out of a bed that's much harder for you to sleep in than a regular bed or I should say regular, but that a bed that a patient that has end-stage lung disease needs. So it's just it seems like, that this would be such a no-brainer, but you're right, Dr. Hampton, we need to be more familiar with these resources that help our patients.
Yeah, I think that one of the other things here, Dr. Pete, that seem to be an issue is that everybody wants to be as normal as possible. And anything that suggests that I'm more advanced than I want to accept becomes difficult. And so for a lot of patients, you just say, I want you to go see this specialist. And if they don't really see it as an opportunity to get something that they see as valuable, then they think that what you're doing is sending me to some place that's going to tell me that I'm worse than what I am, and I don't want to be worse than I am. I don't want to realize that. I don't want anybody to tell me that, and that's a difficult, thing. An issue that we have to deal with patients is helping them to come to a realization, a realistic understanding of what their condition is, where they are, and what are their options. And so as you and Dr. Hampton are saying is that, maybe you won't be able to go and run a marathon, but your normal life will be more comfortable by these additional things. But again, they don't want to give up the idea, even though they may not have been running a marathon. They don't want to give up this idea that you're going to take that away from me. I can't now. You're going to tell me I can't do that, and that becomes so. So these are issues that people have in general. That can't thing, that restriction, that knowing that now I got this thing on me. As long as I can imagine that I can do something, it makes me feel better than when I come to a realization or somebody keep telling me that I got this restriction.
How many of us have patients that are on oxygen and you know that they're on oxygen, and then they show up to your office without the oxygen, and you like, now you look at the chart, you like, where's? I said, now, did anyone take you off the oxygen? No. I said, well, then where's your oxygen? I didn't want to wear it.
Yeah.
So yeah. I hear you, Dr. Miller.
I want to, if I could just throw in something a little controversial, but I just want to, I think that another thing that will affect decision making is there's profit in healthcare. So I'm gonna say it, I'm just being honest. So if I'm a clinician who will be paid well to do chemo, let's keep it real. Is that going to affect my decision making? And I'm not a fool. Like if a patient comes into my office, let me just say this. Now, I'm not suggesting if a patient slides $5,000 in my pocket, will that affect if I accept it, will that affect my clinical decision making? Now, if you don't think that it will, shame on you. So what I'm saying is, if we live in a health system that's profit driven, and I'm going to go to my oncologist colleagues, if they make money by doing chemo, and then if I refer to palliative, maybe the palliative doctor will say, I don't know if you need chemo based on your goals. That's going to be a conflict. So I'm not suggesting we redo the whole system. What I'm saying is that these are the types of things that have been part of our tradition and our system for years. And there's a problem with that. I have a serious problem with that. So those are the types of things that I think about. I don't know. I can't read the mind of a clinician and what they're thinking and what they're doing. All I'm saying is that people need to be given options, and it shouldn't be, clouded by poor judgment based on that. And that's why I believe we should have a system where profit is taken out of it. We all want to make a good living. There's no doctor on this panel that doesn't want to keep making the money they made in the past. But we have to take the profit out of healthcare. Should not be a profit center. It should be a human right. And until we start doing this differently, we're going to continue to have these conversations.
So
we'll have one of those discussions on tomorrow in oversight and government reform, because we are going to be discussing why is the cost of pharmaceuticals so high. We were talking today about one pill that costs $190. One pill. They're popular pill that we hear advertised almost every time we turn the television set on, at $190. We're going to be asking the makers of that pill, why is it $190 for one pill?
So, Representative Davis, I'm going to tell you, I think, quite honestly, to Dr. Hampton's point, it's because that's good for the bottom line. And that is the bottom line. It's good for the bottom line that we charge $190 as opposed to $90, as opposed to $45. What it really is worth, what it really costs to make it, is irrelevant. They just slapped a tag on it that's going to improve the profit margin, and stockholders are happy. So yeah, you're right, Tony. We're in a situation, we're in a catch-22 where the business of medicine sometimes trump why we do what we do. I will say, to your point about the oncologists, and sometimes I don't know that it's so clear about if they're making decisions based off of profit. I do think sometimes to every hammer, every situation looks like a nail. So I know just really good oncologists who feel like that if I can give you chemo and extend your life from 3 months to 6, then they won. and they feel like, yay, I won. But
Right.
what did it cost? What meaning the person's well-being, the in and out of the hospital, the family, the bleeding, the whole side effects. But they feel like I gave you 3 more months but it was 3 months of in and out of the hospital.
Right.
I spent a month and a half in the ICU. So, and to your point, the palliative doc will bring that to the surface. That look, you're really talking 3 more months. You're really talking, but I do think the oncologist. I'm just trying to give them an easy out.
Yeah, clean it up a little bit for me.
Yeah, they look at every situation like, because I have to deal with the family says, well, they think I have a good prognosis. It's like, what do they call good? See, so if in their minds, I gave you 3 more months to live, so I'm doing a great job, and that's why. And think about it. That's what that's all they do is give chemo, and so to them, the fact that you haven't died in a month, I did it. I'm doing a great job for you. So I don't know that it's so profit driven in their mind. I don't know.
Right. Yeah.
But wouldn't you pay a lifetime for one day in paradise?
No, I think also that the thing is that when someone is you're back to your hammer. When someone is given a situation, they feel that they need to do something. And they need to do something that you couldn't do, because that's why you sent this patient, because they're supposed to be able to do something that you can't do. And sometimes it really isn't about that. Sometimes it's about making the evaluation, say, well, you know what you're doing is all that I can do, so there's no reason to go through this extra step. But human nature is always, I think, not just forget about the money. I think we also have this drive to be one up on the next fellow. And I think that sometimes end up hurting ourselves as well as the people that we are caring for, because we are trying to be, more important than we actually, we lose our importance, because when sometimes the important thing to do is just to verify that what is going on and what treatment is being received is the appropriate treatment, and there isn't anything else need to be done. But so I think that's an issue as well with all these circumstances.
Aren't there people who would say, go ahead and pull the plug on me, don't spend any more money on me, and whatever I've got, I'm going to leave it to my grandchildren, or let them have it, so just take me on the Smith and Thomas?
Well, yeah, I think that certainly there are those situations, but I think one of the other things here is also that when and I don't know, again, I don't know what's been happening over the past couple of years, but when we talk about advanced directive and end of life decision being made by individuals for their own life, we don't find a big part of the population actually doing that in a formal way. And I think that's an important, and so now what happens is when they get to the point that they are no longer able to speak for themselves, then that decision becomes somebody else's. And if you're not discussed with that somebody else what you want and what you'd like, they are going to make decisions based on how they feel either how they feel about you or how they feel what you would. And they may be that may be something very untrue, but that's also one of the issues that we have.
Mm-hmm.
Well, it is that time, and I know you guys hate to hear me say this, but right before we do our closing wrap up, let me let all of you know on this panel, you do whatever you need to do to save my life. I don't care what nobody says.
You hear me?
You hear me? I don't care who money you spending, and I don't care how much of their money you need to spend. You do whatever you need, and if somebody tells you I said something different, not true. You do whatever you need to do. Just make sure I don't feel it, but you do whatever you need to do to save my life. That's what you do. You fight for me. Y'all better fight for me, or I'm gonna come looking for you. Y'all better. So now I have put it out there. I'm telling you, That's what I won't do. Whatever you need to do to save my life. Being a Christian, I know that we were born to die, but I ain't ready to go right now. And I need to be caught up in the rapture. And I sure don't want to leave here from COVID. That's why I do what I do. That ain't how I want to go. Angela Underwood says that I always learn something when I'm here. So thank you, Angela, and thank you for being here. Barbara Ivory said this is her first time here, but she'll definitely be back. David Kelly said thank you to the doctors for always sharing such valuable information. We are grateful for your passion for healthcare and the medical science. Linda Johnson says again, great information. Again, great information. Thank you, Linda, for sharing that with us on today. Thank you, Jerome Montgomery, for stopping by and being here with us. Thank you, Evelyn. Virginia Knight says, not me. I want all of my own time on this earth healthy. Yeah, I'm going to be healthy again. I'm a fighter. You do whatever you need to do to save my life right there. Archie J. Cox says, I'm with you, Nikki. That's right. That is right. And Nellie says, me too. So listen, I done told, if somebody signed a DNR, it wasn't me. Tear it up because it didn't come from me. Tear it up. As we're going to go around the panel one more time just to tell us what is your until next Monday. So Dr. James Miller, your until next Monday.
We had an interesting discussion this evening, and I think that we talked about health, but we talked about life. It seemed like more than we usually do, and when we talk about life, I mean, we find that it is valuable, and so the thing that we've been talking about a lot is getting your vaccine. Life. You have a better chance at life if you get vaccinated than if you do not get vaccinated. Again, we want to encourage everybody to go out and get your vaccination. All those that have not, I mean, I know that there's been a lot of people that have gotten vaccinated, but I want to encourage everybody that have not gotten their vaccination to go and get it, and also to make certain that if you get advice about the vaccine, about the side effects, about all these other things, make certain that your source is a good source.
Dr. Tony Hampton, you're until next Monday.
I remember a while ago reading a study, probably that was given to me from palliative care clinicians, and it talked about, it was a nurse that interviewed people at the end of their life, and what did they want to talk about, what did they say, and it really wasn't about, man, I'm so glad I've got that nice BMW, I'm so glad I had the 5,000 square foot house. They didn't talk about those things at all. They talked about that they actually do something meaningful with their life, and when you think about like how you want to spend your life, and you think about how you want to spend your last days, let's focus on the quality of those days. And I think we can learn a lot from people who have left us already. So, we just want to make sure that when people are at the end of their lives, that we help guide them in a way that honors and respects them with dignity. And I think that hopefully, those who are listening to this will, kind of encourage their clinician to do the same. Say, well, we just want you to hold our hand and talk to me with honesty and decency. And that's kind of what's happened in healthcare. We're not like, telling people what to do anymore. We partner with people and we ask them, what do they think? What do they feel is best for them? And I just think you sometimes have to coach your doctor towards that model. So those are my words for today.
Wonderful. Dr. Douglas Graham, you're until next Monday.
Well, I just wanted to support what Dr. Hampton said, and that patients now have more choices. You don't have to take the chemotherapy. You can try hospice care. You can try palliative care. You can go back and forth. So the big problem, the big issue about being a patient is being aware that you have the choices and asking what they are and what they mean for you and your family. Because it's really tough to go down the wrong road and then have that, I wish I could have, should have. So it's hard asking those questions, but come to the visit with the questions written down. Go to the next visit with the questions written down. Make sure you ask all the questions.
Great. Ask those questions. You are absolutely right. Dr. Maya Green, you're until next Monday.
Well, thank you, and it's nice to see the doctors here. Congressman Davis, Nikki, thank you for welcoming me back to the talk. Until next Monday. I mean, next Monday I want to talk about this HBCU thing because I think y'all went to HBCU. I did not know that. I went to Alabama A&M. I'm a bulldog. Normally we can go back and forth. I want to do some signifying now, but this is not the place. Let's do that later. You know, I'm a bulldog, Alabama A&M. I got my burgundy on. Boom. Now, until next Monday, we talked a lot about, like Dr. Miller said, life and transition and homegoing, as we call it. We talked a lot about spiritual preparedness. I think we touched on it, being spiritually prepared for a transition. Something that we don't talk about in our communities, I think Dr. Miller talked about, is being or putting our family in other ways, like the Bible says, a wise man leaves an inheritance for his children. So that doesn't necessarily have to be a financial inheritance. That's good, but life preparedness, you know, an inheritance of not grieving and understanding what I want for my life, for my children. So if something happens to me, they know what to do and they can do it without feeling bad. You know, if they decide to let, you know, pull or something like that, they don't have to feel bad or they don't have to feel the weight of that decision because I've already been made it. So it's a good time to talk to your primary care doctor or teams and your families about a transition plan. We plan spiritually for this magnificent transition, right? And then we leave a lot of times the natural part kind of in the weeds and hanging. So think about that. And then maybe next week we can get into this HBCU thing because I didn't know that.
All right. Dr. Pete, you're until next Monday.
Yeah. So first, I'm going to piggyback off of Dr. Maya, and I appreciate my colleagues here. I learn so much when I talk to you guys once a week. I do want to highlight the fact that I know the CDC changed their mask guidance this week, and you know I'm sure we're happy about that. And what I would just say to encourage more people to get vaccinated, I think President Biden said that we're at 60% of people who have gotten at least one dose of their vaccine. So that's an accomplishment. I would just encourage people to use some common sense with the CDC guidance, and there might be circumstances where you can take off your mask, but you might leave it on. Again, my dad used to always say, "Common sense ain't so common," but I want you to use some common sense, and that if you're in a crowded place, it's not ventilated very well, put on your mask. It's okay. And then let somebody ask you why you got on your mask, because CDC said blah, 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 blah. Say, but I got common sense too. Okay. So that I'm just going to leave with that. And then I look forward to having the HBCU conversation, seeing how Alabama A&M is the second best HBCU there is.
I mean, we could teach you some things, but my time is up. It's not my turn.
Second best.
Well, know that pneumonia and flu numbers are down just as well because these masks have been on. So once again, I'm going to share. I thank the CDC for coming up with in reference to the coronavirus. But as an asthmatic, I'm going to have my mask on. I'm going to have my mask all up around in here.
And you got all the pretty masks, so don't let them go to waste. You can still wear them.
I'm going to have that on.
Right.
They must not have the pretty mask you got. That's what's going on.
I'm going to have that on. I'm going to have it on. To those who actually sent us the questions, and we got an abundance of people who kind of sent the same question or was around that same question, which should we be concerned with our children who have diagnosis with autism and the vaccine? And could the doctor shed some light on the rumors about the vaccine and infertility? We have not forgotten your questions. We just couldn't get to them tonight. And we know that that is a burning concern of yours. So we will definitely start with those questions on next Monday. So we will be starting with that on next Monday. So I just wanted to say that because I did not want you guys to think that we forgot. Hundreds of you kind of asked some kind of way of the same question while I was sitting here going through it. We just couldn't get to it tonight. Just want to remind you to wear your mask, wash your hands, and to social distance. We are very close to being where we need to be. So I want to remind you of that just as well. And as always, join us here on Monday night, same that time, same that channel right here for Couch Conversations with the Doctors. Make sure that that mask is around your nose and mouth. I shared a photo of someone who had their mask up here and I couldn't understand that. So make sure that your mask is in the proper place. And of course, we will have all of our closing statements from our congressman who created this platform for us to be here to share this informational session with you on Monday nights. That's our very own Congressman Danny K. Davis.
Well, thank all of you so very much. And Dr. Maya, I just want you to know that Dr. Alma Adams from North Carolina A&T is the chair of our HBCU caucus. And we do have a press conference about HBCUs on Wednesday that a number of us will be at. Our distinguished chairlady of the caucus, Representative Joyce Beatty, of course, went to Central State. And I mentioned earlier that her husband just passed away, brother Otto. But my nephews like those Alabama schools. Mickey went to Alabama A&M. He liked it so well until he stayed in Montgomery, and he is still there.
A genius and a scholar. He's a genius and a scholar.
Yeah. Well, the other one went to Tuskegee, so that's he just down the road a little bit. But all of them are great, and I certainly trust that there are young people who recognize the tremendous value. I saw the young lady who worked on creating and developing the vaccine. I think she was on MSNBC. And while I didn't know a lot about what they were talking about, I was extremely proud to sit and watch her and to know that she had a hand in doing that. And since Dr. Miller brought up and raised the issue of life, maybe I'll just end by using something that a poet said about life. The poet said that I bargained with life for a penny, and life would pay no more. However, I begged at evening time when I counted my scanty store. But I found that life is a just employer. He gives you what you ask. But once you have set the wages, then you must bear the task. I worked for a menial hire, a penny, only to learn dismay that whatever price I had asked of life, life would have willingly paid. Meaning whatever you put into it,
That's right.
that's pretty much what you get out of it. So thank you all so very much. And I'll tell you about these 2 health hearings that I'm going to participate in on tomorrow and Wednesday. So thank you all. Thank you, Nikki. Have a good night and a good week.
Good night, everyone.
All right.